Hello, everyone. We will get started now. My name is Jillian Lee, and I'm honored to serve as the CEO of National Alzheimer's Buddies. Welcome to our 5th annual virtual symposium. We are truly grateful to have you with us today. National Alzheimer's Buddies is a nonprofit organization that seeks to alleviate the social and emotional challenges faced by individuals living with Alzheimer's disease and related dementias. We do this by fostering friendships between college student volunteers and residents in memory care facilities who we refer to as buddies. These connections help to engage residents and reduce the feelings of isolation often experienced by those living with dementia. Today, we are thrilled to celebrate our 15th anniversary, and thanks to the incredible support of our community, we now have over 50 college chapters across the United States with more than 1,250 student volunteers, and we are continuing to grow. Now I'm excited to pass it over to Leo, our wonderful Chief Impact Officer, who, along with his dedicated team, have put together an incredible event for us today. Leo, take it away.
Hi, everyone, and welcome. My name is Leo Zhang, and I serve as the Chief Impact Officer at National Alzheimer's Buddies. Each year, we host this virtual symposium in order to bring together experts, share knowledge with our community, and inspire meaningful conversations on the challenges of dementia care. Our theme this year, Navigating the Journey of Dementia, reflects the diverse ways that dementia can impact individuals, families, and communities over time. Our goal is to shed light on these experiences and highlight the resources available to support our most vulnerable families. Over the next 2 hours, our speakers and panelists will explore the journey of dementia from a wide range of perspectives. They'll enlighten us on the current state of care in the US and globally, address ethical considerations for patient-centered care, highlight future research priorities, and share effective ways to make a difference in our local communities. As we have outlined in the event itinerary, the symposium will feature 2 keynote speakers, a panel on disparities in dementia care, and another on community-based interventions. No matter your background or experience with dementia, we're so glad that you could join us today and hope that you will find something to take away. All right. Well, as we begin the first part of our symposium, Lived Realities Across Diverse Populations, we recognize that no two experiences with dementia are the same. Each individual, family, and community faces unique challenges shaped by their social circumstances, resources, and support systems. To help us explore these diverse experiences, we are honored to welcome our first keynote speaker, Dr. Elizabeth Edgerly. Dr. Edgerly is the Senior Director of Community Programs and Services at the Alzheimer's Association, where she oversees nationwide initiatives to serve individuals with Alzheimer's and their families. She is a licensed clinical psychologist with a specialization in geropsychology and plays a crucial role in the association's efforts to provide high-quality care, educational resources, and support services. Dr. Edgerly is dedicated to enhancing the quality of life for all those affected by dementia, with a particular focus on equitable care. In recognition of her significant contributions, she was honored as one of the Silicon Valley Business Journal's 100 Women of Influence in 2023 for her advocacy and work on behalf of thousands of individuals living with Alzheimer's and related disorders. Please join me in welcoming Dr. Edgerly.
Thank you, Leo. Thank you, Jillian. And hello, everybody. It's a pleasure to be here with you. I'm going to start sharing my screen here. So let me get that going. Get that set real quick. There we go. Okay. We will move it on back. While I'm doing that, I just want to say thank you to all of you who are involved with this organization. It's been a long time since I was in an undergrad and graduate student focused on working with older adults. That's what I became interested in. And I can tell you, if your organization existed then, I would have been thrilled and very much involved. So thank you for your interest in the field of Alzheimer's and helping people living with dementia. I wish that there were many, many more people like you doing that. And so sincere thanks to you for doing that and for allowing me to join you today. So first up, I wanted to share, I represent the Alzheimer's Association here, and I think that some of you may have some involvement with the association. Again, thank you for that. The association focuses really on 2 major things: accelerating research, and focusing on quality care and support. So today I'm going to be talking to you about the needs of the community, and in particular, how do we ensure health equity and address all people with dementia? And I'm going to reference the different aspects of the work that we do at the Alzheimer's Association. Because if we want to realize a vision of a world without Alzheimer's and all other dementias, it's going to take a lot of different approaches, both at the individual level and even at the societal level. And that's what the association is focused on. So what I'm going to walk you through is a little primer on Alzheimer's and dementia. I know that probably a lot of you could do this part of the presentation, so hopefully you'll come away with some new nuggets of how to present on it. And then I'm going to do a pretty deep dive in who's impacted, and in particular, who is disproportionately impacted. Then I'll go into diagnosis and treatment, risk reduction, and what are the barriers that we are trying to overcome to really create change. So first, the basics. Dementia. Now, dementia is a term that I find most people are confused by when they first hear it, and for many families, they are confused for years about what this means. The number one question I get asked is, what's the difference between Alzheimer's and dementia? So as I'm talking, I'd love for you each to think about, can you answer that question really solidly? So here's how I talk about it. Dementia is an umbrella term. It's a general term that refers to someone having difficulty with memory, other thinking abilities. It could be judgment and reasoning and communication, and it's severe enough to interfere with daily life. So when my mom was diagnosed with dementia, I knew she was having trouble that was more than you would expect for a woman of her age. But what it didn't tell me, and what I asked her doctor, is what is causing the symptoms of dementia. So dementia just says, person's having trouble in these areas. What it doesn't tell me is what's causing those symptoms, and it matters. It matters what's causing the symptoms. So here is a partial list of the kinds of things that can cause dementia. Alzheimer's being the number one, vascular issues, Lewy body dementia, that's what my mom ended up having, frontotemporal lobe dementia, and others, AIDS-related dementia, alcohol, Huntington's, etc. And many people have mixed dementia, where it's not just one cause, especially common to see Alzheimer's and vascular in the same person. So let's do a little deeper dive on Alzheimer's, because that's the most common cause. Estimates vary, but it could be 60 to 70% of people with dementia have Alzheimer's. So we tend to focus on that, but not everybody does have Alzheimer's. So Alzheimer's often first affects memory, and in particular short-term memory, and also things like thinking and reasoning, and it can eventually affect people's behavior, where they may respond to the environment around them in ways that they wouldn't have previously. The symptoms gradually get worse over time and make it so that people have difficulty handling things. Often early, it's finances and managing things like watching out for scams. I got another one today, a request on my cell phone that was a scam. I got 2 yesterday. That's the kind of thing that if I started to have dementia and Alzheimer's, I would not be able to recognize that very well. So Alzheimer's is progressive, gradually gets worse, usually over a number of years. And in the early stages, it can be quite mild and people can function very well. Over time, people lose the ability to do things independently and need more and more care. And sadly, it is a fatal disease. It will ultimately take people's lives. So what are the hallmarks? Well, the first hallmark that we look for is plaques. Plaques that are deposits of a protein called beta amyloid. You may hear out there that the amyloid hypothesis was ruled out and it doesn't apply. Well, that's not exactly true. That by very definition, Alzheimer's is defined by the presence of amyloid plaques, and I'll show you more about this later, and neurofibrillary tangles, and both of these need to be present in order for someone to qualify as having a diagnosis of Alzheimer's. And you can see this on the screen, the example of the brain and the difference in the person with Alzheimer's versus not. Essentially what we're looking at there is atrophy or cell death, because beta amyloid is toxic and causes things to die in the vicinity of the amyloid plaque, and tau causes brain cells to completely collapse and die. So we have a double whammy happening there, as well as a number of other things I'll talk about later. So what we know now, and this has evolved, so over the last 10 years, our view of Alzheimer's has really changed. We used to really think about it only starting in that mild part right there, that we didn't talk much about what was happening before someone got dementia, but Alzheimer's doesn't happen overnight. What happens is, for as much as 20 years before someone would qualify as having dementia, there are changes taking place. So I'm 59, and let's say I'm destined to get Alzheimer's at age 75. I may already have changes in my brain, like amyloid or tau, tangles, and I might not have any symptoms. I think I'm doing pretty well, but it could actually be changing in my brain without me having any symptoms. We are now at a point in time where we can test people and show, gosh, Elizabeth, you've got some changes. We need to intervene. We're also at a point where we're able to diagnose people with mild cognitive impairment, or MCI. Now, what is that? That's where they have the plaques and the tangles, and where they have one significant symptom. So it wouldn't be two, it would be just one of the symptoms, like memory loss. If I had memory loss and I was also having judgment issues and communication challenges, that would be dementia. So if it's one and only symptom, it could be mild cognitive impairment. And in this example, if they show on brain scans that I've got plaques and tangles and I have a deficit, I would be diagnosed with mild cognitive impairment, or MCI. And then you're no doubt familiar with, there's mild dementia, which is people functioning pretty well, and then it progresses to moderate dementia, where daily living becomes a challenge and people need more support, to, for some people, if they live long enough, to severe end-stage Alzheimer's, which means total support and total care. So now Jillian's going to help me, I think, and we're going to show a video. So I can stop sharing, maybe. I'm going to stop sharing and let Jillian share this video, which is the Alzheimer's Association annual Facts and Figures video. So Jillian, if you can do that, I would appreciate it. Thank you. It can definitely torture you, Jillian. We can give up if we need to. Why don't we do that? Let me go back to sharing. Don't worry about it. I'm going to resume my slideshow and just share, because I'm going to actually cover a lot of this. But let me just say, go to alz.org and look up facts and figures, and that will give you a sense of how many people are affected. But we're actually going to talk about this too. So the number of people living with Alzheimer's and another dementia. And let me just verify, are you guys able to see this? There we go. Great. So there are nearly 7 million Americans with Alzheimer's disease. This takes my breath away. And the reason it does is that every year these numbers are growing and growing and growing by hundreds of thousands of people. So it was a long time. When I first started in this field, it would change just a little bit every year. And now, because of the baby boomers, I'm not a baby boomer, but I'm close. Because of the baby boomers and their aging, we are in the tsunami, and it is growing by leaps and bounds, as are the number of caregivers. So we have over 11 million caregivers. I was one of them. Many of you, I imagine, have some experience maybe with grandparents or even parents. So what we know is that not all people, Alzheimer's actually does discriminate. Sometimes you'll hear people say, well, Alzheimer's is an equal opportunity disease. That's not true. It actually discriminates. And I'm going to go through how it discriminates. The first way it discriminates is women. And For the women on the call, excuse me, I have a little text box that will not go away. So hopefully it's not interfering with your view. Women, we are disproportionately affected. Of course, we're more likely to be caregivers, but we're also more likely to have Alzheimer's. 2/3 of all people with Alzheimer's are women. That's an extreme disproportionate impact on women, and we need to learn more about that. We know that menopause may be part of it. There could be a whole host of things, and we're trying to understand why women as opposed to men. Also, Black and African American individuals are 2 times as likely as white Americans to have Alzheimer's and other types of dementia, but they're less likely to get a diagnosis. So what we're seeing, and we'll talk about later, is that people have experienced discrimination when trying to get help. And unfortunately, 2/3 of African Americans, when surveyed by the Alzheimer's Association, believe that medical research is biased against persons of color. And there's more on that. We're going to come back to that. Hispanic Americans, 1.5 times more likely as whites. And what's unique in the Hispanic and Latino community is they're more likely to believe that these changes in cognition are normal parts of aging. So if I think it's just normal for my mom to really start forgetting things, I'm not going to seek help. I'm just going to figure it's what happens. Also, Latinos, like African Americans, report that they have experienced discrimination when seeking health care. Asian Americans, I'm up here in Northern California, and the majority of people in the county I live in are Asian Americans. And so what we see is strong levels of concern from the Asian American community, in particular the Chinese community where I live. And unfortunately, though, there's a strong belief that this is also part of normal aging. So people are worried about Alzheimer's and also see it as normal aging. So that can be a challenge. And they too believe that medical research is biased. And in fact, in many studies, Asian Americans are not included. We're going to see about the numbers for African American and Latinos, but Asian Americans are often completely left out of research studies. For the LGBTQ plus population, older adults who are LGBTQ are more likely to live alone and not have help and caregiving support. And so I'm near San Francisco. It was shocking. The number of people living with Alzheimer's in San Francisco who lived alone was very high. It was between 30 and 40%. And many of them were LGBTQ and had smaller networks and were struggling to get access to care. Native Americans also seeing strong increases, or frightening increases, frankly, in the number of people living with dementia. They're living longer, and as they do, dementia becomes more of an issue. So what have we learned? We've learned that for Hispanic, Black, Asian American families, they are reporting greater care demands. They're using less outside help. And unfortunately, they're experiencing greater levels of depression compared to their white counterparts. And we do see discrimination as a factor. African Americans, Black Americans reported the highest amount at 50%. But look at these other numbers, 42% for Native Americans, 33% of Hispanic, and 34% of Asian. Those numbers are shockingly high. So what would it look like to have health equity? Well, this is what it would look like, and we're going to walk through these. Reducing the risk so people are less likely to get Alzheimer's, and getting access to a timely and accurate diagnosis, getting access to treatment, getting access to clinical trials, and last but not least, comprehensive support. So what would it look like to impact the risk of dementia? Now, this is a general slide that we use for all audiences, and it's a lot in there, and I'm not going to go through all of it because it's quite a bit. But what I can tell you in summarizing this up is there are some things we can't really change, right? We can't change our age or our genetics, ethnicity and race, gender and sex. these things are non-modifiable or difficult to modify. So we're going to, for today's conversation, consider them non-modifiable, and we each get different higher or lower risk based on those things. But there's so much more to the story than that. There's education, there's cardiovascular health, there's diet, exercise. Now you notice I just kind of picked some of them. I picked the ones that have the most evidence for impact. But what we also see that's not represented here is early childhood experiences and that environmental and lifestyle factors that can disproportionately increase risk in diverse populations. So we know there's a lot of work that can be done to lower or mitigate our risk. And for diverse communities, we need to learn even more about what the higher and lower risks are in those communities, because we're not all the same, and we need to understand this better. By the way, we are doing a large landmark study of this exact issue called US Pointer. If you want to look it up, check it out, US Pointer. And the whole focus was to have diverse participants in the United States trying to address risk of dementia. It's going to read out in July, and we'll see what does it take to lower your risk of Alzheimer's, whether you're Latino or African American or white. So the other piece I mentioned that's important for us to see an equitable world of Alzheimer's here would be getting an early and accurate diagnosis. Now, why do this? Because you get access in theory to treatments, you could participate in clinical trials, and you could start putting things in place to maybe improve the symptoms, or even putting things in place like for the future around legal and financial planning. It's also a time for families to really sit down and think about, what do I want and what do I need, and what would I like the remainder of my life to be? So making those end-of-life decisions. One thing I want you to think about, because sometimes we get pushback on this, like, why would I get diagnosed? What's the point? Well, ask yourself, if you were diagnosed with Alzheimer's today, would you do anything differently tomorrow? And in fact, we ask physicians that, because they may sometimes not diagnose. They don't want to ruffle people's feathers. And so I don't know how many of you are medical students or are looking at going into a career related to geriatrics, but I always ask, would you do anything different? I would. I would do things differently if I were diagnosed with Alzheimer's today. So we want families to have that ability. We also want them to have access to FDA-approved treatments. Now, there are symptomatic treatments. Those are the ones that are in kind of this yellow color here. Those have been around for a while, and they can temporarily boost someone's functioning. There's also some that are helpful around sleep issues and some behavioral issues. But the two I want to point out that are really new and unique are the ones in purple, lecanemab, which is called Leqembi, and donanemab, which is Kisunla. And these remove amyloid from the brain and potentially slow the progression of the disease. I know many people taking these. They're hard to get, and they're expensive, and diverse communities are disproportionately not getting access to them, although to be fair, very few people are getting access to them even under the best of circumstances. So Alzheimer's is really complex. It's not, we've got the tau tangles, we've got the proteins, the beta amyloid protein, but there's more to it than that. This is just one of the factors. This is what the treatments are targeting right now, these little yellow amyloid plaques. But there are other treatments in the pipeline that are focused on other new areas of target. And there are more trials taking place on things that are not amyloid focused than there are on things that are other avenues. So if you ever hear someone say, oh, that Alzheimer's research, it's all about this theory, that's not true. In fact, most of the studies that are taking place are looking at different ways to treat Alzheimer's. And imagine a time where it might be like the treatment for HIV, where you take multiple different types of treatments to address it. So here's something we've got to tackle. There is underrepresentation in clinical trials. You can see here the comparison, the light purple is the percentage of the population, 12% for African American, 19% Hispanic, versus the population in clinical trials. Look at the Hispanic participants. So we have a lot of work to do. Interesting, you see the difference. It kind of did a little flip there when we look at Alzheimer's drugs. Hispanics are represented a little bit more, but African Americans are not. So we could be in a place where there is a treatment that does not work for African Americans or Latinos. And we didn't know it because they weren't in the clinical trials. So for us to have this vision of a world without Alzheimer's and all of the dementias, we need to make sure everyone has access to clinical trials and these emerging treatments. So I'm going to stop there. I know we have a panel discussion. I hope I left you with some things to think about and where you can make a mark and impact things. And we'll talk more about big picture initiatives and also things that are maybe one-on-one types of initiatives that make a difference in people's lives. So I'm going to stop sharing and I'm going to turn it back over to Leo.
Thank you so much, Edgerly, for your insightful presentation, for sharing your expertise on the diverse journeys of those living with dementia. We really are so grateful for your commitment to advancing equitable care and support, and we look forward to following the continued impact of your work in bringing high-quality dementia care to all communities. And so, building on Dr. Edgerly's insights, she'll stay on and she'll now be joined by three distinguished experts who, like her, are dedicated to supporting diverse patient populations. Please join me in welcoming Dr. Lynn Weinberg, Dr. Drew Pickett, and Dr. Chi Ude Momo. And before we begin, I'd like to mention that some questions will be directed towards specific panelists. However, all panelists are welcome to share their thoughts, add new perspectives, or expand on points made by others throughout the entirety of the discussion. And let's take 1 minute to look for Dr. Pickett. Okay, I guess then just to begin, could each of you please briefly introduce yourself and tell us how your work supports individuals and families in navigating that journey of diagnosis, care, and also living with dementia? I guess we can go in order. We can start with Dr. Weinberg, then go to Dr. Udi Momo, and then Dr. Edgerly.
Hey everyone, can you hear me okay? Okay, great. My name is Dr. Lynn Weinberg. I'm so honored to be here today, and I am a geriatrician. So I am a physician who is trained in first internal medicine, which is the care of adult patients, and then I've done extra training in the field of geriatrics, which focuses on patients generally 65 and older. And in my field, we focus a lot on what we call geriatric syndromes, which includes dementia, but also other issues that affect older adults, such as managing medications, mobility, things like that. And I am coming from Pittsburgh, Pennsylvania. I work at Allegheny Health Network, which is a large health system comprised of 14 hospitals across Western Pennsylvania, many outpatient clinics, and most of my clinical work is in the outpatient or office setting. So I see patients all 65 and older, both for primary care, and then I also do consultations in the outpatient setting. So I see patients who need to be evaluated for concerns around memory, falls, medications, and things like that. I am also very passionate about programs that can help larger numbers of patients who are struggling with these issues and their families. One of those programs that I'm very closely involved in is called the Aging Brain Care Program, which is a model that came out of Indiana University, and we were fortunately able to get some grant funding to be trained on this model. And in this program, we work very closely with the caregivers of patients living with dementia, and we provide them with extra training, support, help in navigating resources, help with stress management. And we've been doing this program for the last couple of years, and we're very excited that we will have some additional funding through the Medicare Guide model, which is going to start for us this summer. Thanks.
Wonderful. Thanks very much, Dr. Weinberg and Dr. Edgerly. That was an incredible presentation. So I just want to start by thanking the organizers for inviting comments from myself, say Gillian and Leo. You guys are doing an awesome job, and hello to everyone here. So I'm Dr. Chi Ude Momo. I'm trained as a translational neuroscientist. So what that means is my work kind of intersects through the continuum of like working with experimental animal models through to human and clinical care. So I've been working in the field of dementia epidemiology, really focusing on predicting dementia, so early detection. And more recently, I've been leading and driving several prevention programs, really thinking about ways to contextualize how we can effectively prevent, but also improve quality of life outcomes for people living with dementia. So, a keen hat that I wear very close to my heart and what I'm most passionate about is global brain health equity. I completed a fellowship recently at UCSF in California. Yes. And this was and so I'm now an Atlantic Fellow for Equity in Brain Health. And what that means, that's really driven a lot of the focus now of my research programs towards ensuring equitable access to dementia diagnosis and care. And I'm now leading left several efforts across different global populations from the US to the UK. So you might tell from my accent that I am British, but also in low middle income settings where Dr. Edgerly was talking about underrepresented groups. So my work really spans across Africa alongside Asia. And what we're doing in my lab is trying to develop contextualized but also very tailored prevention strategies to start to reduce the risk, but also delay disease progression and improve quality of life for those affected by dementia. One thing I should mention is a key aspect of the work that we do. So our lab really adopts, it's called a living lab approach. And what that means is a participatory research approach that really prioritizes the voices of the individuals that live with dementia. So people with lived experiences and their families across the entire care pathway, so all the way from early detection and diagnosis through to long-term support. And because I collaborate so carefully and closely with community partners and people living with dementia, one example of how this has informed my own work is that I've identified that functional activities and behavioral issues are key concerns that impact people's quality of life outcomes. And so in response, I've started to co-design resiliency-focused strategies that are aimed at preserving independence, but also well-being for longer periods. So I lead the Africa Fingers Consortium. It's a large network of about 14 Africa countries developing these very tailored interventions. And I'm also doing a similar work under the leadership of Dr. Laura Baker with the U.S. Pointer trials, one of the world's largest dementia prevention trials globally. But because I integrate these lived experiences into my research and intervention development, this work really ensures that we can have more enhanced early and accurate diagnosis. And I'd be really pleased to talk a little bit more about the work that we're doing to build these sustainable support systems globally.
Wow, what an amazing group of people. I'm so honored to be on the panel with both of you. I know you all got to hear a little bit from me, but just a bit about my focus too, and it overlaps so much. It's really wonderful to hear from both of the other speakers and the important work that they do. There are a few things that I've seen come into shape over the last 30 years. I've been with the Alzheimer's Association a long time. And one of the things I was really fearful of was that we were going to have emerging treatments that only white people would get to have access to. That not only would people who African American or Latino or all persons of color wouldn't get diagnosed early enough or be able to get access, but that the treatments might not even work. And so that has really motivated me personally to try to change that. And so I'm so proud of one project that I got to work with here in California, and it's called Dementia Care Aware, and it was a statewide initiative. UCSF was the lead, and Dr. Anna Chodos, who is a good friend and colleague, partnered with the Alzheimer's Association, where our focus was across the state to help primary care doctors ask the questions to see if someone was having cognitive impairment and ultimately either refer for a diagnosis or even do a diagnostic workup in the clinic. And the focus was in particular in diverse communities at what are called federally qualified health systems, FQHCs, to see if we can just make sure that there's some equity there where people are going to get a diagnosis and then get access to treatment. This program is still taking place, but it's one thing for all of you to think about is when you think about what impact you want to have, remember there's all these different levels, and it's so interesting because we're each talking about multiple levels. The impact we have on a person in front of us, right in that moment to change their day or their month or their year. Then there's also what can we do on a bigger level, maybe to impact physician behavior or a system or the guide model that Dr. Weinberg, I'm so happy to hear you mention that. And then big picture, like how can we keep people from getting Alzheimer's and other dementias, not just here, but worldwide. So these are things that hopefully excite you when you think about those of you on the call where you can have an impact. There's so many things that you can do to change the world when it comes to Alzheimer's and equity.
Thank you all for your responses. It's really clear that each of you really contributes a unique perspective to dementia care, whether that's through clinical practice, research, or different community health initiatives. So our next question based off that is, in your work, what are the most significant sociocultural or systemic barriers that you've encountered that you realized hinder equitable access to Alzheimer's care?
I can start if that's okay. I think one of the major barriers that we have to overcome, and I know there's been some mention of this already, but it's access to good primary care around geriatric issues and issues of aging. So not just dementia, but really even more broad than that. But I have the opportunity to live in both worlds of living in a primary care world and doing primary care myself. And in my practice, I'm actually embedded into a primary care clinic. So I work right alongside of other physicians that don't have the specialized geriatric training that I do. And I'm closely involved in some of the workflows for multiple of our other practices in our health network. And even going through my own training in medical school and residency in internal medicine. And we are just not taught in basic medical training hardly anything about dementia. So primary care docs are really poorly equipped to address these issues when they do come up. For one thing, screening is not widespread enough. And part of that has to do with systemic factors. Our national experts in preventive care are currently not making a strong recommendation for cognitive screening as part of just regular preventive care. They're not recommending against it, but they're saying more research needs to be done. So many places probably aren't doing it at all. I know Medicare and CMS, which is the Centers for Medicare and Medicaid Services, they do believe in screening for cognitive disorders. So as part of something called the annual wellness visit, which is a yearly sort of wellness focused screening type visit that should happen for all adults who have Medicare, so mostly 65 and older, there is cognitive screening as part of that, but many PCPs are not doing that in really a strong evidence-based way, or if they are doing it, they don't really know what to do next. Couple that with the fact that patients and families are often not bringing these concerns to their primary care docs until very late because they're worried about the stigma of what it might mean to have themselves or their family members diagnosed with something like Alzheimer's or dementia, or they feel that it's part of normal aging, which I know Dr. Edgerly mentioned, but that is a huge factor that I see in my everyday practice, is that many people really think it's part of normal aging. So we need to be screening earlier. We need to be screening everybody. And then we need to work with our primary care doctors to help them know what to do next. And we need to build our workforce of specialists who really have a strong interest in older adults and cognitive disorders. So if people need more help beyond what their primary care doc can provide, they have a place to be able to send people for further recommendations, further testing for patients that might have kind of a complicated presentation. And right now, we even struggle with that in our own health network and broadly here in Pittsburgh. And we are a home to really great healthcare in Pittsburgh between University of Pittsburgh Medical Center and where I work, which is a separate health network, but also very large. We should have these services figured out, but we have a long way to go.
Um, I hope you don't mind if I chime in, because I think absolutely 100% agree with you, Dr. Weinberg. I think that the limited access to early diagnosis is quite a significant barrier, particularly even so for underserved communities. However, if we just take a step back and we just think, even for individuals who are not traditionally classed as underserved or underrepresented, I think that there is a critical lack of education on the importance of behavioral modifications and lifestyle changes that can reduce dementia risk. And, Dr. Edgerly showed us, that lovely slide with the modifiable risk factors. So even those who are identified as high risk, even targeting those modifiable factors could be quite beneficial. But there's a gross lack of education around this. So I want to give you an example. So before moving to the US, I was at Imperial College for several decades, well, for over a decade at least. And I was involved then with a lot of dementia prevention. So another hat that I wear is as part of the Worldwide Fingers Consortium, which is a global consortium for dementia prevention. I lead the biomarkers and biorepository core. And I've been involved with the UK's National Dementia Plan Actions through the Alzheimer's Research UK. And there was a national Stop Smoking campaign that was led by Action for Smoking and Health, something like that. And what we found in this national survey was that over 70% of the population, this is irrespective of education level or whether or not they were high SES or not, they were completely unaware that smoking affects brain health. They knew that smoking had an effect on cardiovascular health, lung function, but neurodegeneration, nothing. No one had any clue. And if you look at similar data from the Alzheimer's Disease International as well, they did a global survey and they highlighted a complete lack of awareness around dementia prevention globally, particularly when you look at the impact of things like loneliness or reduced social contact, which we know that was exacerbated by COVID-19. And I just think it's really important to address these gaps, these education gaps, alongside early diagnosis. Well, we need to give people something to do once they have a diagnosis, right? And people need to understand that they actually have agency over their own brain health. So if we start to increase awareness, we can start to empower individuals, and this is whatever their age, because it's really a life course approach, I think, that effective prevention will take. And so all individuals, regardless of their age, regardless of their status, need to start to take actions, whether it's through lifestyle modification, whether it's through social engagement, or just proactively managing health, because I think these are important ways to reduce risk and improve long-term outcomes alongside diagnosis.
Fantastic. I agree with everything you all said. And one thing I just want to add to it is, we're involved now with a new ad council campaign that's going to be coming out soon to help people learn about what are the warning signs. So, Dr. Weinberg, it goes so perfectly with what you were talking about is, people don't even know really what's just normal and what should I be talking to my doctor about. And so there's some new campaigns that are happening. Some are focused on the Latino community, some are focused on the African American community, and they're starting to use influencers. So in terms of barriers, Leo, I think that just getting information in a way that says something to you, speaks to you, and feels like it fits your community is really important. So having it be maybe less academic or hardcore medical, but really something that friends might talk to each other about, I think is big. The other thing is, I think as research continues to develop, and when we get to the point where there's biomarkers that are readily available, like a blood test, I think maybe our conversation might change. I hope. A couple of years from now, it might be, gosh, at age 60, you go and you get the blood test, and then we'll still have problems, I guarantee, right? It won't be easy, but maybe we could start to figure out who has Alzheimer's without relying on primary care doctors in the same way. But so there are things that are moving, but still it's remarkable the number of barriers, not the least of which is you have to be very assertive. I believe if you want to get diagnosed, get answers, and get treatments and care. And it's a daunting exercise. I speak from experience as someone who's in theory an expert, and it was the hardest challenge I ever had was getting my mom diagnosed and getting care. And you come away thinking, gosh, it shouldn't be this hard. I don't know if others, if my fellow panelists here have the same impression, but it's like, wow. So imagine if you're not used to arguing with your providers, with your care providers, you may have to sometimes.
You're absolutely right. It shouldn't be this hard. And when I talk about Alzheimer's care locally in my own professional community and where I work, I talk a lot about comparing it to cancer care. And of course, cancer is devastating, but when somebody is diagnosed with cancer or there's a suspicion of cancer, there's a biopsy, there are blood tests, and immediately, at least for, we are so fortunate here in Pittsburgh to have wonderful access to care in the city, but as soon as a cancer diagnosis is made, that person and their family are wrapped around with services. Things move very quickly. We have social workers and dietitians and people that educate about chemotherapy and a lot of support. And when a person gets diagnosed with Alzheimer's or another dementia, there is really nothing. There's nothing clear other than certainly we do refer people to the Alzheimer's Association, and there are different phone numbers we give and things like that, but there is really no good structure for supporting that person and their family. And I'm hoping with some of the work I'm doing that will change, and with some of the programming that our government is coming out with the Medicare guide model, I'm hoping that will change. But I think we still have a ways to go.
Yeah, those really were some great insights. I think public awareness of brain health and cognitive decline is definitely so important. It's actually a perfect segue into the second part of our symposium, where we actually hear from individuals who are currently undertaking efforts to overcome these systemic barriers. And I guess in the interest of time, I actually want to transition over to maybe some audience questions, since we had a couple really interesting questions in the chat. So the first question that I received privately was directed to Dr. Edgerly. How is the progression from mild cognitive impairment, MCI, to dementia typically monitored in patients? And are there any specific interventions at the MCI stage that can help delay further cognitive decline? I guess this could apply to
Great.
Dr. Udi and Dr.
Yeah,
Weinberg too.
I bet all of us actually. That's a really great question. And let me just talk about ideals and then in practice, because sometimes they aren't. Unfortunately, sometimes we see people diagnosed with MCI and they still have that diagnosis 6 years later, and they have clearly progressed. But in theory, what should happen is at least annual monitoring of the person to see, has it progressed to the point where they have symptoms in more than one domain that begin to interfere with daily living. So I mentioned to you that MCI is significant impairment in one type of function. Memory is often the top example we give, but otherwise a person is doing pretty well and they're functioning quite independently. So when it starts to add in another domain, or when it becomes so severe that it's truly interfering with the person's daily activities, that's when you'll see people be considered to have dementia, and then it may be Alzheimer's, or it could be another related type of dementia. I'll open it up to my to the other panelists. Steve, did you want to add anything to that? Do you agree with that? Is that what you're seeing as well?
Yeah,
Okay.
absolutely. And I do think that this is where community sensitization comes in as well, especially for groups where people don't directly access care or where there are stigma attached to having cognitive impairment. So I work with communities where early diagnosis could be almost a form of putting a target on a person's back, because in those communities people get lynched and called witches or whatever if there is any sign of cognitive permanent dementia. So there's a need for community sensitization to explain to people that this is not a natural part of aging, and it's a disease, and we're trying to figure out ways to treat this disease. It's and I think that educating people towards how dementia progresses, ensuring that they understand the benefits of identifying things early so that they can start to do something to at least try to delay the progression. I think community-based efforts are just so key. And we need this, on a global scale.
For me, in my clinical practice, I see mild cognitive impairment as a real opportunity to focus on some of those lifestyle and behavioral modifications, really focusing on good cardiovascular health, exercise, social engagement, staying on a routine. And it's also an opportunity for us to really look at that person holistically from head to toe and look for other things that might be going on in the body that could be contributing to that mild cognitive decline. Often it's medications. Certain medications are very high risk for brain health in older adults. And this is another area where there are a lot of education gaps among people in the community and healthcare providers. Sometimes we are able to identify another issue such as depression that could be affecting the way somebody's cognitive function is presenting, and that's very treatable. So oftentimes if we identify that and we treat that, the person actually becomes a whole lot better. That mild cognitive impairment may still be there and still needs to be monitored, but we can help somebody function better, at least in the present time. Medication wise, as far as some of those medications that are out there for mild cognitive impairment and dementia, I think we still have a long ways to go in improving access to those. And some of the more mainstream medications that we've been using for a long time, it's very easy for a primary care doctor to prescribe one of those medications in mild cognitive impairment and kind of leave it at that. But it takes much longer to really go through some of this other education around behavioral modifications and lifestyle changes. So part of this also is making sure primary care providers have the time to spend with patients and have their schedules and their compensation models structured in a way that promotes them spending time with patients to really focus on some of those other things.
Great, thank you. And the next question from the audience is, how do you all foresee research initiatives and development and also potential clinical care changing with the recent NIH and research funding cuts?
Who wants to answer that? That is a tough one. All joking aside, I'll start. The Alzheimer's Association is watching that very, very closely, as you might imagine, on a daily basis. I don't think we know. We're not even sure all the changes that have already happened in terms of leaders in the field who are no longer with NIA or NIH, and the risk could be great, but we just don't know yet. The one clear thing that at least is held up, though, is the indirect reimbursement for universities. It doesn't mean that less money would be spent on research, but it affects the agreed upon deal, essentially, that the federal government had with institutions to cover things. So that affects the field, and I think we're gonna have to see. But it's concerning. I won't lie. We've seen increases over the years in investing in Alzheimer's science. And I don't know. I don't know what it's going to look like. So I'd be curious what our other panelists think.
I could just say I'm a natural optimist, so
Good.
and I live to Brexit, so so just personally and in my group, I'm seeing this as and I'm taking obviously thinking about what types of research are being funded. I don't think that's going to take away from my focus, which is around health equity for everyone, because I've
Yeah.
always had the lens of coming into this space as wanting to ensure that everyone, regardless of their status or any other social demographic characteristics that we label people with, everyone has access to healthcare. And so, a lot of even the national programs that I'm running within the US, like the DAC Healthcare Preparedness Program, which is ensuring equitable access to a diagnosis using it's helping primary care physicians, like Dr. Wayner, by training people called brain health navigators, towards like patient education and care coordination is still going on. And so we're not relenting in our kind of vision around ensuring that everyone has an accurate diagnosis, increasing access to everyone for clinical trials, but also, prevention efforts. And so I guess I could say that, yes, there are all these, there's a lot to be concerned about, I suppose. But I think I also go on a diet of not paint, like trying as much as possible not to encourage a lot of negativity. It's hard, but but because negativity just breeds fear. And so I'm just carrying on the work that I'm doing, and just continue to do the best that I can.
I completely agree with what you both have said. I also try to be a natural optimist, and in some ways, I think issues that affect older adults, especially brain health, is such a global issue and it's on so many minds. And part of me really wants to believe that that would not be an issue that's targeted as far as really dramatically cutting funding. But I do worry about the health equity piece, and that is an issue that will not get the funding and attention that it deserves.
Yeah, it's so good to hear that it doesn't change all of our overall missions. We're still working for the same cause, for the same goal. And I guess in the interest of time, to end, we'll try to end on a more positive note. So we'll do a little like a personal question then. So this is adapting Anna Baldwin's question from the chat. But in just a few sentences, like what do you love most about what you do?
I'll start. I will also say, I think Dr. Edgerly said in the beginning of her presentation that if this organization had been available to me when I was a college student, I would have been first in line. I have known for probably my whole life that I've wanted to work with older adults. I started out volunteering in the nursing home where my mom worked as a nurse when I was probably about 11 or 12 years old, and have always had a natural comfort with older adults, people living with dementia. And I love what I do. I love working with families, especially. I really love those relationships that I get to build with my patients and families, and seeing them through the hard moments of the dementia journey and then through to the end of life, and really helping people navigate this journey with dignity and staying true to what matters to them is just the most rewarding thing that there could ever be. So I just remain inspired, even with all the barriers and the challenges and all of the things that we've talked about that are hard. I keep going, and I really love what I do every day.
I think I have very, very similar experiences and drivers as well. I do have a personal motivation, in the communities that I serve, but also from a personal angle, having lost both my parents, several aunts and uncles, to dementia. I am personally motivated to try and find a way, um, to ensure that, and also being a mom now, to ensure that it doesn't affect me, it doesn't affect my future generations, it doesn't affect anyone I know, love. So at first it was a thing of interest. I've always been passionate about the brain. I've always been passionate about how we learn, how we remember, and that's how I got into into the space of neuroscience and neurological disorders. But then it became really personal when I started to experience tragedy, and I realized, hang on a second, we need to figure out a way to ensure people have access to understanding whether they're at highest risk, and if so, what can we actually do to stave off this horrible, awful disorder. So I won't. I can't even think of any other field that I would want to work in. I am extremely passionate about what I do, and I really like that. There are forums such as this that really allows this sort of conversations and sharing around ADRD.
Wonderful. So mine was a little different. I wasn't immediately drawn to aid working with older adults or Alzheimer's, but it happened in graduate school when I started taking a course on the psychology of aging, and it just felt fun. Like I really enjoyed it in a way that was different. And then when I started actually working, maybe like Dr. Maybe both of you actually in a nursing home, I did a rotation, and people would say to me, isn't that depressing? Like, why do you want to do that? And I thought, this was not depressing. This actually felt so uplifting and wonderful. And I thought, I love this. And I get to work with people with Alzheimer's and learn from them, be inspired by them. And it gets you up in the morning, like nothing else. If you can change the world of Alzheimer's and help someone individually or in a global scale, it's pretty awesome. So I thank you all for doing the work that you do, and for organizing this panel, Leo and Jillian. It's really been an honor to get to be here with you.
Absolutely. Thank you.
Yeah, thank you so much. It was really so inspiring for me, and I'm sure it's inspiring for a lot of the audience as well. So with that question, we'll conclude our Disparities panel, and thank you to Dr. Edgerly, Dr. Weinberg, and Dr. Udimomo for sharing your insights on how we can better support diverse patient populations, better support everyone in navigating the journey of dementia. And I know there were a couple more audience questions in the chat, but hopefully they'll be sticking around, so they can answer your, if you would like to just ask your question publicly in the chat, and then our panelists can continue answering questions throughout the remainder of the session. So having explored the range of lived experiences with dementia, we'll now turn to the second part of our symposium, Tailored Care for a Brighter Future. And this section will really focus on the innovative efforts being undertaken to transform dementia care for impacted communities, addressing both research advancements and social initiatives. So a natural segue again from our previous discussion. So to begin our discussion of these efforts, we are honored to welcome Dr. Tia Powell. Dr. Tia Powell is a prominent psychiatrist and bioethicist known for her contributions to the field of clinical ethics, public health, and bioethics education. She serves as the director of the Montefiore Einstein Center for Bioethics and the Einstein-Cardozo Master of Science in Bioethics program at Albert Einstein College of Medicine. Her academic work spans multiple disciplines, and she is recognized for her expertise in bioethics as it relates to public policy, end-of-life care, and decision-making capacity. Dr. Powell has served on numerous committees for the National Academy of Medicine, including one that recommends research priorities to advance the prevention and treatment of Alzheimer's and related dementias. Her enduring impact on bioethics and public health is a testament to her commitment to improving healthcare delivery while addressing the complex moral and ethical issues faced by patients, providers, and policymakers. So the floor is yours, Dr. Powell. Thank you for joining us today, and we look forward to hearing your insights.
Thank you so much. I hope I'm unmuted, and I hope that you guys will let me know if I'm not, because it will be very boring talk if you can't hear anything that I'm saying. I'm going to ask you guys to run my slides for me. So if we can, whoever's helping me, I'm not sure if it's Leo or Jillian, could you start with the first slide, please? Let me first note that actually the titles that Leo so generously mentioned for me are no longer accurate. About a year ago, I stepped down as director of the Center for Bioethics and also of the master's program. So I have to continue to check with people before they introduce me now. I'm still doing some work for the Center for Bioethics at Montefiore and Einstein, but I'm no longer the director. I'm kind of happy to say, even though I love the people who work there. So I'm going to go through these slides pretty quickly. I didn't know about Dr. Edgerly's presentation or the contents of it, so there's some overlap there, and I'll skip over those things so we have more time. And I know the first part went over a little bit, so I'll try and speed this up so we can get back on track. So why don't we just go to the next slide? We've already heard what dementia is. Let me think with you for a minute about its burden. There are all of the biological functions that are going awry that you heard about before, but there is also, and that's the disease itself. That's how it changes your body and your function. But there's an additional part that creates burden for people who have dementia, and that is what society does with the fact of your having this biological illness. How society sees you, controls or doesn't control people with dementia, how it denigrates or doesn't denigrate them. And that can lead to, those biases can lead to a significant loss of dignity and self-worth for people with dementia. And that combined burden from both the biological changes and the impact of society is much greater than the sum of the parts. So there's the disease itself, which causes problems, but it's also what we're doing about it that causes people problems. And that's a shame. And that's something that we have to do better with. Next slide, please. So what's the role? My lecture is called How Can We Help People with Dementia? And who's that we? Who am I talking about? So I'm going to break the talk into two pieces. Science, scientists, clinicians, researchers can do some things to help people. And then there's something where I want to think with you about the bioethics piece, and that comes closer to that societal role. So next slide, please. All right, so I was lucky enough to just finish having been the chair of a report produced by the National Academy of Medicine that is called Preventing and Treating Dementia, Research Priorities to Accelerate Progress. I'm very pleased to say that Dr. Momo was one of the members of that committee that produced this report, and I had no idea that she would be joining us here today. So next slide, I'm going to tell you a bit about this slide, about this report. When the National Academies of Science, Engineering, and Medicine take on a report, they usually have a very specific task. You must do what's in this task, and you must not do other things. Otherwise, all of these are such big topics. They would mushroom and they would become really unmanageable. So what we were asked to do in this report was to examine the current state of research for preventing and treating dementia, which is an enormous task in itself. Just NIH funding is a couple of $2 billion. Also to assess the evidence, not just on medications, but on non-pharmacological interventions, to look for key barriers to advancing dementia research and ways to address those barriers, and to review what might be some promising areas of dementia research. So that was the task that was set before us by a congressional mandate. Next slide, please. So it's a huge 300-page, very weighty report if you see the physical thing. And I promise you, I cannot adequately summarize everything that's in there in a brief talk. Even trying to do it, I would have to talk really quickly like those people on television in the ads where they're going over the side effects of medications. So I'm not going to do that, but I'm going to give you a broad overview. The three basic categories of recommendations for the report are here. They are: one, look at brain health across the course to predict, screen for, diagnose, and monitor dementia. One of the barriers to studying dementia is that it's not completely clear to us when you still have appropriate health, cognitive health, and when you're beginning to switch over. There are tests that we can do, but they don't translate very well across languages and cultures. Some are very pencil and paper oriented, and that can be quite hard because as we get older, we develop various disabilities, including arthritis, which may make it hard for you to either operate a computer tablet or even write things or draw a clock face by hand, which is one of the basic questions that people are asked to do that. So we need to do a better job of figuring out how can we really study this in a way that's scalable, that's easy for lots of people to administer. Second, how can we build a more integrated understanding of the biology and mechanistic pathways that lead to dementia or resilience to dementia? This is an enormous scientific question. This will be the future of helping people with dementia through science and scientific research. We're not there yet. We don't understand all of the different interlocking genetic and other kinds of pathways. And that's where some very good people are focusing their work. We also need to catalyze advances for preventing and treating dementia, from looking at precision medicine, which matches the person to their specific genetic profile and the type of dementia they have. We've made huge advances in breast cancer, for instance, by being able to really focus on precision medicine. What's the exact treatment that will work for this person that might not work for her next door neighbor? And looking at public health strategies. So those are the three big basic categories. Next slide, please. So a key take-home message, and I was not aware of Dr. Edgerly's slides. This is not in some ways made to contradict her, but it's an important scientific piece. We say very often, as Dr. Edgerly did, Alzheimer's is not the most common form of dementia, but it's actually not the most common form of dementia pathology. Relatively few people have only the plaques and tangles of Alzheimer's. The majority of people who have symptoms of dementia have mixed pathology. And that's actually quite important for our research. They have, vascular is actually the most common pathology, but people with symptoms tend to have more than one thing, sometimes many things. So they may have vascular lesions, they may have the plaques and tangles or Alzheimer's, which are certainly very common. They may also have indications of Lewy body disease, of frontotemporal dementia, and of a relatively new entity that's really puzzling. Clinically, this person looks like they have Alzheimer's disease, but they don't have excess amyloid plaques. For the longest time, we only thought of those people as somebody who got in the way of Alzheimer's research, but it's a separate illness, and they have dementia, and we owe them research that will help get them into a better place, help prevent or treat this. So next slide, please. But again, apologies to Dr. Edgerly, whose talk I thought was very interesting and wonderful. And I'm not trying to set up a fight here. So the challenge of dementia treatment today is that most of our patients actually have multifactorial dementia, but we have relatively few medications that address the root causes of even Alzheimer's, and we have no FDA treatments that address the neuropathologies, the root causes of the other dementias. So for a case in point, a person I know, a brilliant architect, started to have clear cognitive changes. He was aware of it, his loved ones were aware of it, and he went, and his brother is a physician, excuse me, and advised him to get an evaluation, and was told that he had Alzheimer's disease. But this person's symptoms were unusual. He had lots of hallucinations, and really it looked like to his clinician family member that he had Lewy body disease. So he was sent then for another evaluation, and this is not uncommon in the diagnosis of dementia. Most people are not going to big research centers where the best information is available. So he ended up getting another evaluation, and they said, yes, you do have Lewy body dementia. We don't really have much to treat that. You also have Alzheimer's pathology. Maybe we can give you those medications and see if they help. That's not good enough for our patient population, to take nothing from the medications that can help people maybe slow down the development of Alzheimer's. If somebody says you have this disease, you don't want to hear, well, I don't really know how to treat that, so can I treat this other disease that you may or may not also be causing your symptoms? We have to do a better job for treating all of the dementias. So how do we do that? Next slide, please. Well, that's a huge research question, which I hope we'll be better at solving after another decade or so. One is to identify risk factors in diverse populations, particularly those who are disproportionately affected, primarily minority groups. Second, let's characterize the exposome, which is a relatively new word in science. It means everything you're exposed to in your environment. So that could be things that are helpful to your cognitive health, like having more education, or fitness, or a great diet. It could be things that are harmful, like air pollution, or lots of stress, or various different things. So the exposome is everything that you're exposed to. And then think about gene-environment interactions. Can we elucidate the genetic and other biological mechanisms underlying resilience? How do some people have even lots of neuropathology, but they don't get the symptoms? They live a long time and don't have cognitive impairment. How can we get some of what they have? That would be great. And how can we develop an integrated molecular and cellular set of causal models that really tries to pull together the various dementias? That might be the best way to help people that have mixed neuropathology. If we had something that was way above the stream, that didn't look at just one particular type of dementia, but that was helpful for a variety of types, which is that's what people have in terms of neuropathology. Could we do that? So next slide, please. Okay, I love this slide because it is overwhelming. This was a slide designed by one of the other committee members, Christian Bale, who is a German neuropathologist, and tries to pull together all of the different things that affect cognition and can lead to dementia. I won't walk through it, but if you were to go to this report from National Academies, which you can get by Googling the title of it, you will be able to download that for free, and you could see this report blown up in real time that looks at a lot of different things. And some of these pathways affect, we think, all types of dementia, such as inflammation. That was looked at very early in the study of dementia, and we didn't get too far. We tried to use drugs like the non-steroidal agents and didn't make much of a difference in terms of it, but it looks like we have to go back and do our homework again and relook at how inflammation plays a role, because it seemed to play a role in various different types of dementia. I won't go through more, but I'll say there's a lot of different things. Down here, you see the plaques. They're absolutely in there. They seem to be playing a role in dementia. I don't think they're the only thing, though, that causes dementia. There's lots of different pathways. Is it partly your immune system? Certainly the neural cells that, in a sense, take away the trash, cells that are no longer working, those seem to break down in interesting ways, and that seems to have an important impact on the development of dementia. There's also changes in the blood-brain barrier, where we have that barrier to keep toxins and other bad actors out of our brain, and it definitely can break down. So what's up with that? Is that's a target that we could address in terms of making interventions that would be help with people, maybe prevent dementia or treat it once it's there. Next slide, please. And I apologize for how overwhelming that slide was, but I want you to see how complicated the problem is that people are working on. The next batch of recommendations, and again, this is just a brief summary of all the different recommendations, is to integrate innovative approaches that look at the way we do research, the planning of research, the design of research, and the execution of studies that will identify effective interventions. Advance the development of combination therapies. That's where we're really weak so far. So you're, unlucky, you have symptoms of dementia, and they can see doing studies of your brain that have different types of neuropathologies. What can we combine? What different medications? Or can we even combine medication plus a behavioral trial, plus diet, plus all kinds of different things, especially ones that we begin to understand can be helpful? Can we try to figure out how we could borrow from other fields that have been more successful, like breast cancer study, like the study of heart disease, and begin to pinpoint specific therapies that are really great for people who have this particular factor, say a particular genetic variant or another kind of factor, a particular behavioral variant. How can we identify what's really works for certain populations? Because we know we are not all alike. How can we adopt standardized outcomes for intervention? This is a real problem in research generally, but certainly in dementia research, with how can we find outcome measures that make a difference to the patient, that say, I feel better, I see changes because of the intervention that you've done for me. And too few of our dementia interventions today can really produce that. And public health interventions. What can we do at a population level to really improve and protect the cognitive health of everybody in our population? Next slide, please. So innovative clinical trials, this is really interesting stuff. You don't need necessarily more money, you don't need technology that we don't have, but you need to really mix it up. So a traditional clinical research trial takes a really long time to produce the data. Typically, you get your participants, you screen them, you figure out what's going on, you set up an arm of the trial. These people are all going to get the active intervention, and these guys are going to get a placebo. With some diseases, the placebo is standard intervention and the active intervention is something more. So with people with cancer, for instance, we don't give anybody a sugar pill. We give them standard treatment, and then the active arm is something else on top of that. Well, that's what happens. Then you stop what you're doing, you've got it all done, you've got all your data, you analyze that, and that can actually take a long time. And certainly before supercomputers, it really took a long time to figure out all the data. Then you publish your results. That can take up to a year as papers go back and forth, being re-edited, asking for more tables, do it this way, do it that way, and then the results come out. There's a wonderful trial, and this happens in a number of different fields, but this is a breast cancer trial called I-SPY. They tested multiple agents in the same trial, and they would take cohorts and inform the people that were being enrolled later using the results of the earlier trials. So they would change the dose, so they would change the combinations, and they can use much better and more contemporary statistical analysis to get that information out, even for the people who are still in the trial. And they're very good about getting publications out faster and really disseminating these results. We need more of that. And that is beginning to happen at NIH and elsewhere, that people are really thinking about how can we do research better? What can we change? Next slide, please. So innovative trial design. This was a trial run by Christine Yaffe at UCSF. And I really like this because it's multi-domain and because it really partnered with the participants in the trial. It's called the SMART Systemic Multi-Domain Alzheimer's Risk Reduction Trial. All trials, they always have to have an acronym. So this one's SMART, S-M-A-R-R-T. What the researchers did is that they got this group of people to participate in the trial, and they said to them, you have these various different risk factors. Maybe you're a smoker, plus you have high blood pressure, and you look like you're getting diabetes. And you can try a lot of different things that might help you with those. Which factor is most important to you? And which of these interventions that are all reasonably likely to be helpful, which do you want to work on, and which are you engaged in? And the subjects got to choose which risk factor and which method. And they had actually a much more successful study of behavioral intervention than is common. They didn't fix everybody. They didn't prevent anybody, everybody from getting dementia. It's not, it hasn't solved our problem. But this creative approach actually allowed them to do much better than is common. It is so hard to get people to change behavior. If you have ever had a bad habit that you wanted to break or a good one that you wanted to start, and I confess, I have not been good about flossing my teeth, and it's so important for dental health and also for heart health and maybe even for cognitive health. I've had so much trouble with that. So if you've had a problem, you know it's really hard to change behaviors. They did it in this trial, and it was really impressive. So we need more of that also. We need creative thinking, and we also need to treat people who are in research as our partners, because an engaged person is one who's much more likely to follow through, and that will be good for them and good for the rest of us because we'll get better data. Next slide, please. So now I'm going to switch. That's really focusing on science and the report that I was lucky to work on with other people. But I'm a bioethicist, so what can we do about that? How can you do that? Well, I'm going to tell you, bioethics has a lot to do with helping people make choices that accurately reflect their values, their preferences, that make them feel that I know that you want me to do X, but for me, that's not the best choice. I'll have to tell you also, most choices in life are not in the medical context, and bioethics may be able to help us with choices not just about medical care, but choices can be sometimes inflected by medical information, good or bad. I'm going to mention to you one of our other committee's members on the report was a wonderful woman named Doreen Mux, who's a retired nurse. She was told, and you can read about her story in the preface to the report, She was a nurse who was told that she had early onset Alzheimer's disease. She was given the advice that she would be dead in 8 to 10 years, that she would very soon be very significantly impaired, and that she should really change her life. And she took that advice seriously. She sold her home of many years. She moved into assisted living facility, and she had other people protect her in terms of her banking and various different things. After about a year, she realized, I'm not actually getting worse very quickly. And to make a longer story short, she had to move back out. She had to undo a lot of that because she actually didn't need an assisted living facility. She was so high functioning and so busy with her new career of being an advocate for people with Alzheimer's that she didn't really like the restrictions of the place, and she wanted to live on her own, always referring to her family to keep an eye on her and to help her. It turned out when she enrolled in a trial, she flunked the enrollment criteria because she doesn't have excess amyloid. And she is still on the journey to figure out what is the nature of her developing cognitive problem. But it's not Alzheimer's disease. No one intentionally did anything bad to her, but we are not great at communicating medical information clearly, in helping people make decisions. It isn't only the job of the physician, but when one of the earlier speakers, I think Dr. Weinberg, was saying, there's not somebody to step up and help you when you have dementia the way there is with cancer. If she had been able to talk to more people, she might have heard from somebody who said, dementia is very heterogeneous. People develop at different rates. If you're comfortable now, maybe you can make some plans to do things, but maybe you don't have to make all of those changes right now. You play it as it lays. It would be the wrong advice for somebody, but it would have been the right advice for her. So we need to do a better job of helping clinicians communicate medical facts and helping patients make choices that will serve them up well. Next slide, please. All right, so I'm going to talk very quickly. I'll actually only do, I'm going to just go through these very quickly because I want to make sure that I am over. I think I am at time. So I'm going to say this. I'm actually not going to go through these. There are 3 risky decisions. I'll just tell you what they are that affect all adults. Adults get to make risky choices if they want to. You young adults would be happy to hear that. I'm sure you're out there discovering the risky and less risky choices that you can make. But ones that are particularly important as your cognition begins to changes include money, sexuality, and guns. I can figure out, I'm going to ask Leo a question. In order to get us back on time, I have to stop now. Do you want me to talk for another couple of minutes, or do we want to go to question and answer, and I can figure out how to make sure that people have access to my slides if they want that? So let me put a question to the organizers and ask what they'd rather have me do.
I think it's fine to talk for a few more minutes. We can
Okay.
start the next panel at 1:40 or 2:40
Okay.
Eastern.
2:40. Okay, I'll talk for 5 more minutes. All right, so next slide, and I'll go quickly. All right, so financial choice. Bummer. Your financial cognitive skills often disappear more rapidly than other skills. That's really tricky because your family talking to you and seeing you at family events and that kind of stuff may have no idea that there's been a change in your cognition until later they discover that you have been really scammed by people in a different country trying to sell you crypto, trying to sell you gold bars. And you cannot do this work without having people tell you horror stories about somebody who worked hard all their life, patiently saved their money so that they wouldn't have to worry in retirement, only to trip over cognitive changes at the last minute and have all of that money disappear just as they were retiring. It's really tragic. And people are trying to do good things to make sure that there are greater protections, but we are not there yet. Financial abuse of adults is a multi-billion-dollar business in the United States. Sadly, this is often by family and friends. And if somebody gives you money voluntarily and you've not been declared to have poor decision-making capacity, it's very hard to undo that. Next slide, please. So ways to fix this are when somebody gets the diagnosis of mild cognitive impairment or early stages of Alzheimer's and other dementias, maybe that's a good time to sit down and think about what are your values, what are your preferences, what are your plans. Can you connect with professionals? Can you work with your family to figure out how can there be safeguards? You don't want to burden anybody, but you also don't want to tempt anybody and have somebody that you love end up going to jail because they misuse your funds. As somebody progresses, there are some mid-level steps that you can take. There are some banks that now allow somebody to have read-only access to your account. So maybe as you're getting older and maybe you're having some initial symptoms or even a diagnosis of mild cognitive impairment, maybe your kids can read your bank account, but without changing it. But then they would see if you start making $10,000 money orders off to a foreign country, where as far as they know, you don't know anyone. And then in the last stage, when you really have advanced dementia, you should not be making financial decisions. That's not something that's compatible with the significant limitations on cognition that are diagnostic of the late stages of dementia. So then you need somebody to watch over you. Next slide, please. So sexuality is obviously a big topic. I cannot do it justice, but I'll just tell you some of the issues. This is a part of human dignity. This is a part of being an adult. And by the way, there is nothing about having cognitive impairment that means you can't be lonesome or wish to be comforted by someone who cares about you and that you care about. There are also many, many unhelpful biases. There's a bias that older people should not be sexual, that people with impairment should not be sexual, and that men but not women should be sexual. So all of those together make it very difficult, actually, for people to see clearly the older person who has questions or behaviors that seem troubling relative to sexuality in the context of cognitive impairment. Next step, please. So what we used to do was not the best way to go. There was a lot of gender bias where if there was any sexual behavior, for instance, in a nursing home, which is what SNF stands for, a skilled nursing facility, men were seen typically as perpetrators. Women were seen as, oh, well, that's kind of cute or that's silly that she's doing that. But it meant that there was quite a punitive attitude sometimes towards men, where any kind of sexual expression led to discipline, restraint sometimes, and expulsion from the nursing home sometimes, without an attempt to say, this is part of the illness. This person has lost their filter. How can we respectfully protect this person and everybody else around? Does it really need to come to restraints? Is that where we start? Many women were seen as victims, so if there was any kind of sexual relationship between men and women or between women and women in a nursing facility, this was just seen as, that's clearly terrible and inappropriate. We have to stop that right now. And it wasn't necessarily how the person themselves felt about it. They would ask the staff, staff and family would often make decisions without consulting the person living with dementia. And indeed, they were also excluded from questions that involved them very, very dearly. Next slide, please. So we don't have the solution to this yet, but there are now great nursing homes and other places that are beginning to really try to assess the capacity of the person to make sexual decisions that reflect their own values and what they want. And when you have good capacity and really understand what's going on and you're really making this choice, knowing what the risks and benefits are, really nobody needs to be in your business. You are still an adult. And people in nursing homes do find relationships. They are old, they are lonesome, and they are seeking comfort. And why is that a bad thing? So you might offer counseling and collaboration. As the person goes kind of further down in terms of cognitive function, there may be times where you need to limit access. If you really feel that one person's taking advantage of another, or the other person doesn't understand what's going on, you may have to do limited access, and you may have to really do full protection when somebody is, really at the final stages of dementia, when they don't even necessarily respond to people, so they don't know what's going on, and that person needs protection. That's a big topic done quickly. Next slide, and then I think I'll leave it there. All right, I just want to tell you, guns. 44% of U.S. households have guns, but that's not as many as households with dementia. Half of U.S. households that contain a person with dementia have guns. And older white men have particularly high rates of gun ownership, dementia, and suicide. This is not a good setup, completely apart from politics. I will say the VA, jumping a few slides ahead, the VA has actually done some wonderful work normalizing the assessment of guns in the home for anybody with a new diagnosis of cognitive impairment. They say, okay, things you need to think about: driving, guns, this, that. If they're in the house, how do you store them? Who has access? Is ammo separate from the gun? There's also a wonderful program called Safety in Dementia out of University of Colorado. And there we go, thank you. Designed by the physician Emmy Betts, which really is totally apolitical. It's just the facts, ma'am. Who's got the guns? What do you think about it? What do you think about safety? And tries to address this with people while they're still able to sort of express their values and preferences. And it's really important. It's not a blue state, red state question. It's a question of, do you want to, when you have dementia, shoot your wife, which happened to a man in West Virginia who turned out to have Lewy body dementia, had guns in the house, didn't recognize his wife, and shot her and killed her, didn't shoot his granddaughter who was sitting next to her on the same couch. That's not good for anybody. So this is a huge problem that needs to be addressed and has been very poorly addressed so far in our country. So if you didn't have enough things to worry about, I'm going to leave you with that. And why don't we go on then, Leo? I'll leave it at that and hand you back the driver's wheel there.
Sounds good. Yeah, thank you so much, Dr. Powell. It's a really comprehensive overview of all the ongoing efforts to improve our understanding of what it really means to live with Alzheimer's, and also appreciated the promotion of that person-centered approach to dementia care. So we'll give it 1 minute as we arrange the stage and bring the panelists up. But as we now know, much of the journey of dementia kind of unfolds outside of the hospital. And as Dr. Powell mentioned, one key research priority is assessing those non-pharmacological interventions, such as public health strategies, which are really crucial for delivering care that upholds patient dignity and values. And so with that holistic perspective in mind, Dr. Powell will now join our next panel, which will discuss important factors to consider when designing these broad-scale community support initiatives. So please join me in welcoming Ms. Kirti Kulsa, Mr. Bert Brodsky, Ms. Catherine Lawrence, and Ms. Esther Pearl. And again, we want to emphasize that although some questions will be directed towards specific panelists, everyone is welcome to share their thoughts, add new perspectives, or expand on points made by others at any time throughout the discussion. And so that being said, we'll start by having each of you just giving a brief introduction and your relationship to Alzheimer's and dementia. And I think we can just go in order as well. We can start with Ms. Kulsa, then move to Mr. Brodsky, then Ms. Lawrence, Ms. Pearl, and then we get in with Dr. Powell.
Thank you. I'm Kirti Kulsa. I'm the CEO and co-founder of the Alzheimer's Research and Prevention Foundation. I'm happy to be here, honored to be here to meet all your Alzheimer's buddies and your volunteers. And I've learned so much during the webinar. So Mr. Brodsky, it's nice to see you again. We go back a long way.
You as well. Thank you. I'm Bert Brodsky. I am the founding chairman and the chairman of the Alzheimer's Foundation of America. I was involved because 55 years ago, my mom had it. And when I give a little more discussion about it, I can give you experiences that when Alzheimer's was taboo to speak about. It was something that people didn't discuss, and you didn't mention it, and you lived with it, in retrospect, very poorly.
Hi, my name is Catherine Lawrence. I am a registered nurse. I've been a nurse for a little over 20 years and have spent the majority of my career caring for patients and supporting their families that are older. I currently work as the Elder Life Nurse Specialist at Allegheny Health Network here in Pittsburgh, Pennsylvania. I work with Dr. Weinberg, and I find that I'm doing a lot of connection between the patients as they go through, you know, primary care, and I also work on the inpatient side. And I also am involved in the HELP program, Hospital Elder Life program. So we work with a team of volunteers that see patients in the hospital. So I spend a lot of my time in that field.
I can share. I don't know why my camera is not working. We're going to try to work on that. But my name is Esther Pearl, Program Manager with the Connecticut chapter of the Alzheimer's Association. And my journey with Alzheimer's started in 2011 when my then 56-year-old husband was diagnosed with Alzheimer's. So I came to this field with very little knowledge, very little background, but I've now been on staff for almost 8 years next week, and just privileged every day to have the opportunity to share education, support, and information for those who are living with Alzheimer's and those who care for them.
Sorry. So each from your introductions, each of you really play a critical role in helping others navigate that journey of dementia, whether that's through nonprofit leadership, research, hospital-based programs, or outreach efforts. So from your perspectives, what are the most pressing unmet needs in dementia care and support at the community level? And we can go in the same order, but also feel free to chime in if you have something to add to the discussion.
I'll skip because I know we're short of time, so I'll skip.
Okay, Dr. Powell.
She's on mute.
Dr. Powell, I think you might be muted.
I do that all the time. I'm so sorry. I just wanted to comment about NIH. I think the focus on the heterogeneity of dementia is absolutely crucial. And the notion that you can do good science and not look at diversity and equity and inclusion, that's just not a thing. You can't do scientific research without that. You cannot follow the scientific method. Dementia is an unbelievably heterogeneous disease within populations and across populations. And to understand what it is, you need to look at that variety. So I don't know what the resolution will be, but sort of wiping out, like using an AI program to take the word diversity out of all grants is not science. It is the opposite of science. So something has to be fixed in that problem. And I know that's controversial, but I'm also an educator, and I want to say that for our students so that they hear it. This is a big problem, and it's not okay. I'll stop there.
And although we are short on time, I want to make sure everyone's able to share their journey, share their perspectives. So we will be extending the symposium a little bit, I believe, until 3:15. So feel free to share, keeping in mind the time constraint, but also please don't be uncomfortable with sharing everything you want to say.
Let me tell you what our foundation does, which is not really recognized often in society. Everybody knows about the research, as the doctor knows, and we've not made a lot of progress in this area. Where we have made a lot of progress, and where our foundation is instrumental, is dealing with the family and the person who has the disease. So I go back historically, 55 years ago, as I said, nobody talked about it. There was no treatment. You put the person in a room with or without an aid, and you let them do nothing and kind of mellow out. Here's what's available now to the family. Our foundation has 2,000 agencies all over the country. Here's what we primarily, besides funding research, what we primarily do. We assist those families and the patient who has Alzheimer's. So here's what we've built as a sample to go around the country. We built an apartment that is suited for an Alzheimer's patient almost up until the end. And here's what people don't recognize. As an example, The clock in that bedroom is a digital clock. The bathtub is painted blue because of depth perception that the Alzheimer's patient doesn't have. The telephone has a blocks on them where you just push the block of the picture of the person you want to dial, and you don't have to dial, you just hit the picture. There's a refrigerator with a camera, so someone who's not living with the person can see what they're eating. The stove has a small fire extinguisher above it if it gets too. You can have somebody live a relatively functional life up until maybe 3/4 of their time with Alzheimer's. But you don't have that. People don't address that often enough. The caregiver can drop that person off at a facility, and that person can have art therapy, music therapy, pet therapy. You can keep them as functioning as long as possible. So you don't have to just lock them away and watch them deteriorate. There's something, I don't know if you've ever heard, an inversion room. We had one of our facilities, we're building a second one now, an inversion room where you could sit in almost like a theater, and you could dial in whatever you want to see. If you want to go back to your old neighborhood, you can dial that in, or someone will dial in for you, and you're back in your old neighborhood, in your old apartment, with your old friends. As we all know, the Alzheimer's patient has a problem with current memory, but they do have the ability to go back to their old memory. At least let them function as long as possible in as much comfort as possible. And that's what most do not address. And we do. It's just everybody's looking for a cure, and we are also, but to make the patient more comfortable now is available now, even though the cure is not available. I can continue going if no one else wants to say anything. All right.
All right, I'll go. So I was really touched by the presentations from Dr. Powell, Dr. Momo, and the first panel. And we heard about behavioral choices, and that's really what we're all about. We're about prevention by lifestyle choices. So we founded this organization, the Alzheimer's Research and Prevention Foundation, almost 32 years ago. Next week, and it's really based on lifestyle. So lifestyle choices. We created a program called the 4 Pillars of Alzheimer's Prevention. And why 4? Because we wanted to make it easy to remember, easy to implement. Although, of course, now after 30 years, there's a lot more research on other modalities. But let's keep it simple. The 4 pillars are diet and supplements, because diet is how we all eat, and how what we put in our bodies has a direct effect on our overall health, our heart health, and our brain health. By the same token, supplements, because not everyone is able to have the adequate intake of the right fruits and vegetables and nutrients. So sometimes supplements are indicated. Number 2 is stress management. Thank you, Dr. Powell, for mentioning stress. Stress is rampant. Everybody has stress. We have stress in the workforce. Older adults who, even if they live in an assisted living facility, have stress, financial stress, health stress, their loved ones, right? Uncertainty. This is all stress. It's a stressful time, and stress is extremely, extremely deleterious to your brain. So it's important to manage your stress, learn any way, any modality. We have so much material about this on our website. So you must manage your stress. Number 3 is physical and mental exercise, because movement you have to move. And Dr. Powell said that we want to hear our patients say, I feel better. And movement, I mean, you know, from helping your joints, helping your circulation, helping your mood, everything. Movement is really, really important, and it improves circulation. And guess what? That circulation improves circulation to the brain. So mental exercise, same thing, you know, work, learn something new, experiment new things. It's super important. And I gave Leo some links to free materials, including this brochure on brain aerobics. So for all the Alzheimer's buddies, if you want ideas about new activities to do with your buddy, check it out. It has some fun ideas. And pillar number 4 is spiritual fitness, meaning creating purpose and meaning in life from, you know, religiosity, if that's what you're interested in, to spending time in nature, volunteering, participating in groups, group activities. I've been part of Rotary for a long time, and we have older ladies that knit, you know, caps, and then the other groups that go and distribute them. So how beautiful is that? This is all scientifically proven to help your well-being, help your brain, help your memory, and therefore, you know, stave off Alzheimer's. So thank you.
Leo, if I can, I have something to add. I just love hearing all these directly related and supportive observations that we each have, perhaps coming from different perspectives, but all with these commonalities. I had written some notes earlier, and very similar to what Dr. Weinberg mentioned on the last panel. I think one of the first things that I had experienced with my husband, the first doctor to diagnose him from a neurocognitive testing perspective, after 2.5 years of testing and doctors, the appointment, we had to drive 2.5 hours from our home in Connecticut to Boston for the doctor to tell us that somebody had booked the wrong kind of an appointment, and he only had 10 minutes with us because his next patient was waiting, and that the diagnosis was Alzheimer's, and he would reach out to our doctor here in Hartford. So then when they did the lumbar puncture and the doctor in Hartford called me, he could not say to me that this was Alzheimer's. I just kept getting, the results are abnormal. The proteins are wrong. And so eventually I got it out, and I said, well, what do I do? And he says, well, call the nurse tomorrow and make an appointment for a year. And I said, no, doctor, you're not understanding. What do I do? And he said, well, I'll call in a prescription. Third time, I said, no, doctor, you're not understanding my question. What do I do now? And so my first and important point was that, as Dr. Weinberg said, I think there needs to absolutely be a clear connection from the doctor's office to the helpline. We have a 24-hour helpline, and we do have a program called Dementia Care Consultation, where we work integrally with many healthcare systems across the country, so that as soon as there's a diagnosis, they are connected with us and get care consultations, information, support, that patient education and support, the family caregiver education and support, and really just that whole continuity of care is absolutely critical. We talked in the last session with some of the cultural issues that there really is still too much stigma, too much fear, too much denial. And I think a lot of that comes from people not wanting to talk about it. You know, 30, 40 years ago, most people, when they had a cancer diagnosis, it was kept very quiet. They didn't want to share it. Now, everybody posts it on Facebook or Instagram the second, you know, they feel a lump or go to the doctor for something. And I think we need to kind of push for the same with various forms of dementia if people are okay with it. You know, I would never share someone's diagnosis, but making it normalized to share that there's a diagnosis or there's a concern. That's, you know, one way we can try to lessen that stigma. We've talked a lot today about diversity in clinical trials, which is absolutely critical. And for people to understand that clinical trials are not just about medications. There are many, many trials, and I'm sure, you know, with all the medical professionals we've had on the calls today that you've seen this. There are trials, studies that have to do with family history, that have to do with caregiver stress. Living here in Connecticut, we are very close to Yale University, and I have the privilege of myself participating in a couple of trials, couple of studies. And they're observational. There's one I do on the computer. And also, when my husband was diagnosed, he made it very clear that he wanted to do something to further the science. And so when he passed away, his brain was donated to the Alzheimer's Disease Research Unit here at Yale for further research, because that was something that he could do in the future. And nobody ever talked to us about that. Nobody ever said something to think about. Do you want to, you know, partake in this? Is this something that you would want to do? But fortunately, I was able to kind of figure it all out on the moment. But just, you know, a few thoughts that I wanted to share there.
You bring up a great point about connecting or educating the community too, because I think sometimes that's a big piece of what's missing. I feel like that's a lot of what I do with the families and the patients at the bedside. When somebody comes into the hospital with mild cognitive impairment, not necessarily a diagnosis of Alzheimer's, but what does that mean to that patient? And how can that care partner help them figure out how to navigate day to day? Perhaps what brought them into the hospital is the lack of that patient just wasn't able to communicate to their family members or their care partners what was going on. And now all of a sudden they're inpatient in the hospital because it went too far. So I think, you know, the being able to work with volunteers in the hospital Elder Life program has been eye-opening for me. The majority of the volunteers I work with are college students. I love having the opportunity to be able to educate them on the difference between delirium, which we can prevent, which is the big part of what we do, but also somebody who has Alzheimer's or dementia. How can we meet the needs of that person, and how can we help to support their family member to be able to have a positive impact and to help them get out of the hospital? I worked a lot in nursing education, so helping, you know, the nurses go to their nursing program, they graduate, they pass the NCLEX, and now they're out on the floor. And I meet with groups of nurses all the time, and we talk about, you know, delirium prevention and recognizing that, but they mix it together with, you know, the chronic condition of Alzheimer's or dementia. So helping them be able to separate that. What can we help? What can we fix or help to prevent? But going forward, if somebody has a chronic condition, how can we help to support them so that they can live their best life, so that they can still remain a part of their community? And, you know, the Alzheimer's buddies, once I found out about that, I'm like, wow, this is great. There's, you know, there's more opportunities to get people involved and help them understand, you know, the difference between the chronic, you know, the chronic dementia as well as, you know, something like delirium that we can help to intervene and help to prevent.
So it's interesting because what was brought up, which we find not up of, is the education to the population, the education to the caregiver, and the education to the family. Our foundation, we do it all over the country, and we run open seminars just to address those areas so that the caregiver can learn how to deal with it. Because you have many of these home aides dealing with the family with no experience in this field. So what we did, one of the concepts we had, since we have 2,000 agencies under our umbrella, rather than have each agency develop their own program, we developed a computer program that goes to those agencies. So each of those agencies can run those programs that we run nationally. So they can educate the family and educate the caregiver. It's the best we can do at this time since they see it. There's no cure for this disease. We can try and postpone it, which there's always that how it really works, what we're doing very well. But we can educate everybody else. And the more people you educate, the word gets out. It's good for several things. First, it's very good for the family and for the caregiver. It's also good for fundraising for the industry. I go to Washington 4 times a year. The last time I was there, the government was at $4.2 billion. The first time I went was $400 million. We can just try and get whatever we can from the federal government, from the local government, and then try and deal with educating as many people as we can.
Yeah, I think we're seeing this common theme throughout the discussion of just how important public awareness of cognitive decline, Alzheimer's, and dementia is. And each of your organizations really plays such an important role in awareness, in that education component, whether it be Alzheimer's Association, Alzheimer's Foundation of America, APRF, or the HELP program. And so in the interest of time, I actually wanted to jump to our last question and gather some insights from you, because you are all managing or part of these really large-scale community-based initiatives. So what is one key lesson from your organization's past efforts that could help enhance future outreach and support initiatives by organizations with students like us, National Alzheimer's Buddies, and potentially other nonprofit organizations out there? And we can go anywhere.
Go ahead,
I think
you go.
I think the biggest thing is for people to know that they're not alone, that nobody should go through this disease believing that they're the only ones, whether it's somebody who has a memory concern, someone who's caring for them. You're not alone. We are here. All of our services are free, open to the public. And we really encourage people to reach out and just start that conversation.
I would say
That's right.
keep spreading the word.
Every community has a facility nearby. They are. You may not realize it, but you can find it anywhere. I'll tell you a quick story. Sue Collins, the senator out of Maine, when I met with her, she told me that her uncle had Alzheimer's, and he was in a small town in Caribou, Maine. Caribou, Maine was the last city before you get to Canada. And we do have an agency there. She didn't even know it. She's a senator and did not realize it was help for her uncle in his neighborhood. And that's just getting help is available if you find it. And it's all available.
Yeah, spreading the word, communicating like we're doing today with all of the Alzheimer's buddies that are watching, you know, trying to organize an event or getting their friends involved, or, you know, just being able to push this information forward.
I think that there is so much need, and there are many resources, as you can see, all of us here from different agencies. Just reach out, you know, reach out. We've all done so many years of outreach, education, research. And so, yes, reach out.
All right, then. And although I'd love to continue the conversation, I also want to respect our panelists and all of our attendees' time. So I guess I'll just ask, for the final question, I'll just ask each of our panelists, including Dr. Powell, just to provide any final thoughts on implementing community-based support initiatives for Alzheimer's.
Was that question to anybody, or was that to the doctor?
Just in general. And I know the last question is also final thoughts, so we can also wrap it up here.
I'll just answer quickly saying I really want to mirror the comments of other people, how pleased and impressed I am to learn about Alzheimer's Buddies. I think that's a wonderful program. First of all, I love intergenerational programs generally, because both young people and older people are lonely, are very isolated. So even apart from dementia, to bring the generations back together, I think is really wonderful. And learning at a young age that it's not just being smart what makes you valuable as a person is valuing other people. It's great to be smart. I know a lot of you out there are smart, but actually empathy is really important, and it doesn't necessarily show up in a standardized test, but it is part of the test of you as a human being. So continuing to see people as worthy of respect and dignity, whether they have dementia, whether they look different from you, whether you understand what their goals are, is just incredibly important. And I know it sounds preachy, but it's so great that you guys are doing that. And I hope that you can cling to that, even when the world gets crazy and you get busy and you have lots of responsibilities, or you feel cynical because you're disappointed in what's happening around you. Please hang on to that part of you, because it's just precious. So I'll quit with that.
Very nice.
All right then. So as we thank you all so much for that really powerful discussion. And so as we begin to wrap up our symposium, it's become clear from today's speakers and panelists that incredible work is being done on all fronts and at every level of the healthcare system to improve the quality of care for individuals living with dementia, regardless of their background. And so their efforts really give us hope in this fight against Alzheimer's disease. So I just want to thank you all again for being here today. And so, of course, thank you. And so to finally wrap it up, we also wanted to highlight some of the National Alzheimer's Buddies initiatives that are currently in place that are related to our what we talked about today. So National Alzheimer's Buddies is also dedicated to helping every family navigate that journey of dementia. So over the past several years, we've actually been working to expand our support for underrepresented and underserved older adults with dementia through our community chapters, which collaborate with local nonprofits like the Alzheimer's Association to offer accessible services. We've served as translators for awareness presentations at Asian American community centers, organized free caregiver respite programs on college campuses, and hosted community meetups at venues like the zoo and art museums. So given the wide range of backgrounds among college student populations, National Alzheimer's Buddies is really uniquely positioned to build these meaningful connections across diverse communities. We have currently established community chapters at Northwestern, WashU, Rice, William & Mary, and UC Davis, and we are actively working to bring community-based activities to Boston, Pittsburgh, and New York. If you're interested in partnering with us, or if you're a student looking to implement community-based initiatives at your college or university, please feel free to reach out to me at leo@alzbuddies.org or submit an inquiry on our website. In addition to our virtual symposium, we're excited to announce the launch of our spring merchandise fundraiser. And so you can now purchase a variety of items, including t-shirts, sweatshirts, tote bags, and stickers. 100% of these proceeds will go directly back to supporting our chapters. And two of our talented volunteers, Michelle Lee and Barbara Lopez, actually designed some of the merchandise you'll see today. And so to shop, simply visit our website at www.alzbuddies.org/shop or scan the QR code. The price of each item includes shipping costs and 2.9% credit card transaction fee. We're also proud to partner with a local small business in Winston-Salem, North Carolina, who will be producing all of these items. And as a thank you for attending today's event, everyone here will receive a 10% off coupon code for your entire purchase. Just enter NAB 2025 at checkout. Again, that's NAB 2025. And if you have any questions, feel free to reach out to us at merchandise@alzbuddies.org. And with that, we'll conclude our 5th annual National Alzheimer's Buddies Virtual Symposium. As Jillian mentioned, 2025 marks the 15th anniversary of National Alzheimer's Buddies, and we wanted to thank everyone for joining us today. Thank you again to all of our speakers and panelists for your thoughtful contributions, and thank you to the National Alzheimer's Buddies executives and interns for their contributions to making this event a success. So at this point, you should see a survey link in the chat and also up on the screen. We would really greatly appreciate if you could fill out this in order to receive feedback for us to receive feedback on today's event. It shouldn't take longer than a minute, and by filling out that survey, you'll be entered to win a $25 Amazon gift card. Additionally, since we are a nonprofit organization, we always welcome donations to help us improve our outreach to all of those living with dementia across the U.S. So if you're so inclined, you can donate to us through our website or the QR code on the right. And finally, please be sure just to check out our website, allsbuddies.org, for regular updates on our organization's work and for more information about how to get involved. Thank you to everyone again for taking the time out of your day to be a part of this event, and we hope that you all have a wonderful weekend. Thank you so much.
And with that, we're going to close out today's session. Thank you all for staying on. I know we went a little over time, so we appreciate you staying for the remainder of the talk. And please feel free to visit our website at www.allsbuddies.org. Thank you, everyone.